All right, let's talk about something that's an absolute must-know for your orthopedic exams: fractures in children. Seriously, you can't just think of these as small adult fractures. They've got their own unique patterns, their own risks, and it all comes down to the fact that you're dealing with a growing skeleton. So let's break down exactly what you need to know. So, the first thing you've got to get your head around is this: a child's skeleton is not just a miniature adult skeleton. Its properties are fundamentally different. I mean, pediatric bone is way more flexible. It has that active growth plate, the physis, and get this, the ligaments are often stronger than the bone itself. It's a completely different world from the brittle, fused skeleton of an adult, and that dictates totally different injury patterns. And because of that flexibility, you get these really specific fracture patterns that you will only ever see in kids. Let's take a look at the three main types. First up, we have the bowing fracture. The best way to think about this is to imagine bending a green twig. It holds that new bent shape, right? That's pretty much what happens here. The bone undergoes what we call plastic deformation. It bends, but there's no visible fracture line. It's a perfect example of just how elastic these bones are. Then we've got the torus, or what we also call a buccal fracture. This is a compression injury. The cortex just kind of wrinkles and bulges out, almost like a ripple. It's an incomplete fracture, and it's a super stable sign that the bone has failed under compression. And the third classic pediatric fracture is the Greenstick. You've probably heard of this one. The bone gets bent so much that the tension side, the outside of the curve, snaps, but the compression side, the inside of the curve, it only bends and stays intact. Okay, now this is a really critical point, and one that loves to pop up on exams. For Greenstick fractures, you have to intentionally complete the fracture during the reduction. You have to break that intact cortex. Why? Well, if you don't, that intact side acts like a tether, and it'll just pull the bone right back into that ugly, deformed position while it's healing. You've got to break it to get a stable reduction. Okay, so we've covered fractures of the bone shaft itself. Now let's shift our focus to probably the most critical and vulnerable area in a kid's skeleton: the physis, or the growth plate. Injuries here are so important that they get their own special classification system. Get this, a whopping 75% of all growth plate injuries fall into one specific category. That makes pattern recognition here absolutely essential. You gotta remember this number, because 3 out of every 4 physeal fractures you come across are gonna be a Salter-Hires type 2. This table gives a great bird's eye view of the 5 Salter-Hires types. But to really lock these in for your exams, there's a fantastic mnemonic: Salter. Just think S for straight across, A for above, L for lower or below, T for through, and ER for erasure or crush. Let's dig into what each of those looks like. Okay, starting with type I. This is a nice, clean separation straight across the growth plate. That's the S in Salter, straight across. And because this fracture doesn't mess with the reproductive layer of the physis, the prognosis for future growth is usually excellent. Next is type 2, and remember, this is by far the most common one. Here, the fracture line goes A for above the physis and exits out through the metaphysis. This creates that classic sign you've got to look for on an X-ray, a little triangular piece of the metaphysis called the Thurston-Holland fragment. If you see that fragment, you're looking at a type 2. Now for type 3. This is L for lower or below the physis. Here's the thing you have to remember. This is an intra-articular fracture. It goes right into the joint surface, and that changes everything. Anatomic reduction is absolutely 100% critical. Any little step-off or irregularity you leave in that joint surface is a setup for post-traumatic arthritis later in life. Type IV is the T for through everything. The fracture line goes from the joint surface, through the epiphyses, across the physes, and into the metaphysis. Just like a type 3, it's intra-articular. But the big risk here is growth arrest. Because that fracture crosses the physis, you can get a bony bridge that forms, tethering growth and causing a nasty angular deformation over time. And finally, type V is ER for erasure or crush. This one's tricky. It's a pure compression injury to the growth plate. The initial X-rays can look deceptively normal, which means this injury often gets diagnosed way later, only after you start to see a growth disturbance. It carries a really poor prognosis for future growth. So when you see these fractures, the big question is, what's going to heal on its own, and what do we absolutely have to fix? This brings us to the incredible principle of remodeling. It's pretty amazing, actually. A kid's bone can remodel like crazy. Sideways displacement, what we call ad latus, and angular deformity, ad axum, will almost always correct themselves over time with growth. This is especially true the younger the kid is, and if the deformity is in the same plane as the joint's motion. But, and this is a huge but, this is the one exception you cannot forget, especially for your exams. Rotational displacement, or ad peripheryum, will not remodel. Never. Why? Because growth can correct angles, but it can't untwist a bone. Any rotational mistake you leave behind will stick with that patient for life. It has to be corrected perfectly at the time of injury. All right, let's boil all of this down to the key take-home messages that you absolutely have to know. Okay, 4 things to burn into your brain. 1. Recognize those unique kid fractures, Bulging, Torus, and Greenstick. 2. Know that Salter-Harris type 2 is the king of physeal injuries. It's the most common. 3. If a fracture involves the joint surface, like a type 3 or 4, it demands surgical precision. And 4. Never, ever, ever accept rotational malalignment. It doesn't remodel. And this all comes back to a fundamental rule in pediatric orthopedics, the Merck-Janssen rule. It's simple. The prognosis is better the sooner reduction is achieved. For any of these injuries, but especially those involving the growth plate or the joint, getting it back in place early and accurately is the key to preventing long-term problems. So, I'll leave you with this to think about. Why is getting a perfect anatomic reduction of type 3 and IV fractures so absolutely non-negotiable? Really consider how just a tiny step off in the cartilage or a small bony bar across the physis can have these massive, lifelong consequences for a patient's joint and their ability to move.